Klockan är 12. Vi inleder dagens seminarium med webbinariet med Kristin Liljekvist som hälsar välkomna.
Hej, jag heter Kristin Liljekvist och kommer från Innovationsrådet. Och det här webbinarieserien om design och hälsa är ett samarbete mellan Innovationsrådet, Stiftelsen Svensk Industridesign, Vinnova och SKL. Och eftersom det var vi i Innovationsrådet som fick äran att inleda just den här delen så tänkte jag inleda det hela med att säga några korta ord om vilka vi är och vilket uppdrag vi har och våran koppling till det här ämnet. Och Innovationsrådet är en statlig utredning som leds av ett råd med 5 ledamöter. Och ordförande är Dan Eliasson som till vardags är generaldirektör på Försäkringskassan. Sen har vi 4 ledamöter. Birgitta Berlin som för närvarande är tillförordnad generaldirektör på Tillväxtverket. Det är Carola Lemne som är vd på Praktikertjänst. Thomas Rolén som är kammarrättspresident i Stockholm och som för närvarande leder den här utredningen om polisens nya organisation. Och så är det Håkan Sörman som är vd på SKL. Och själva praktiska arbetet leds av ett kansli där vi är 4 personer och jag är då en av dem. Och uppdraget som vi har fått från regeringen då är att vi ska stödja och stimulera innovations- och förändringsarbete i offentlig verksamhet som då ska leda till betydande förbättringar för medborgare och företag. Och man har också pekat ut att vi ska ha ett helhetsperspektiv och vi ska då lägga fram ett förslag på hur man systematiskt kan förbättra arbetet med innovation och utveckling i offentlig verksamhet. Och det här är ju väldigt breda direktiv kan man säga, 15 sidor långa och man kan koka ner det till att vi ska förbättra förutsättningarna för att vi ska få antingen bättre kvalitet för samma pengar eller samma kvalitet för lägre kostnader. Och hur gör vi då det här? Det här är ett sätt att förklara lite av det. Vi gör dels olika former av kartläggningar och dels en enkät till myndigheterna om hur de jobbar med innovations- och förändringsarbete och kvalitet. Vi tittar på hur mycket kvalitets- och effektivitetsanalyser som görs och studier av regelverket, hur lean kan appliceras i offentlig sektor och så vidare. Vi gör en del praktiska utvecklingsprojekt kring bland annat miljöprövningsprocessen, hur olika myndigheter samverkar kring zoonoser och massa andra saker. Och vi för även mycket dialog, dels med myndighetschefer och också en bredare konferens som vi ordnade med SKL och Vinnova i höstas. Och 2 av alla de slutsatser som vi har dragit av det här arbetet är de här 2. Dels att vi tror att det finns en stor potential i att i ökad utsträckning involvera medborgarna i offentlig tjänsteproduktion. I planering, i genomförande och i utvärderingen. Och där tror vi att offentlig sektor kan komma längre och göra ännu mer för vi har sett att det ger bra resultat runt om i världen och i framförallt sjukvården då. Och vi tror också att man bör pröva skarpt i liten skala i större utsträckning. Istället för att bara utreda och gissa vad som kommer hända om vi implementerar någonting så tror vi det är bra att pröva i liten skala och dra slutsatser från verkligheten och sen skala upp om det visar sig lyckosamt. Och de här 2 slutsatserna är ju ganska väl förknippade med vad tjänstedesign handlar om och den metoden. Så därför tycker vi det är väldigt kul att få vara här idag och vara med och arrangera den här serien. Och den här lilla boken i hörnet här visar att vårt betänkande är på väg. Det kommer komma i juni, i början av juni i år. Och där kommer vi presentera ett antal förslag på hur vi tror att offentlig sektor kan bli mer innovativ. Och också fler slutsatser och mer resonemang bakom de här. Och om ni vill kontakta oss eller läsa mer och ta del av de rapporter som vi har släppt under tiden så kan ni gå in på vår hemsida som är www.innovationsrådet.se och mejla kan man göra på info@innovationsrådet.se. Och där kan man hålla koll på vad vi gör och kommer också ladda upp betänkandet där den är färdigt. Och med det sagt så ska jag lämna över till Andreas som ska berätta om några mer praktiska detaljer och också introducera våran föreläsare. Varsågod.
Tack. Hi, I'll switch to English. My name is Andreas Hager. I'll be moderator today. Help bring questions forward. We have 20 minutes of a lecture first and then we will have questions. You can post questions by Twitter using this hashtag, DesignFBH, Design for Better Health. I'm here because, not because I'm a lawyer, but because my great passion in life is to find ways to involve patients and citizens in the development of healthcare and other support systems for long-term illness. So for me, it's a great pleasure and honor to introduce Jason here from the Beryl Institute, and I think you will start by telling us a bit about who you are. So I'll leave it at that. Welcome.
Thank you so much, Andreas, and good morning, everyone. I'm going to wave. You can all wave back so I know you can hear me. There we go. It's interactive already. But I just want to thank you all for the time this morning, for the opportunity to speak about this, I think, very critical topic on the power of patient expectations. And we're going to touch on that from a number of different perspectives as well. My name's Jason Wolf. I'm the executive director, actually now the president, excuse me, of the Beryl Institute. I've come out of the healthcare sector and out of the service sector for most of my career, and have taken on this work in the last 2 to 3 years. It truly is a work of passion to ensure that the voices of patients and families are a consideration in all that we do in providing the best care experience from the quality, safety, and service that we provide within the healthcare world. So I'm excited to spend some time with you today, just briefly to talk about some of my thoughts around how we can begin to look at the data, we can begin to look at the situations, we can begin to look at the reality of healthcare today and how we can begin to come together to ensure the best experience for everyone. I'll go to the foreign language portion of my presentation and just say tack så mycket to the organizations who have brought this together and brought us together today, both in the room there that I see and those of you gathering online. I do reiterate, I think, what Andreas said, would love to see you all contribute to the Twitter feed, and the opportunity to have ongoing conversations on this topic is very important to us at the Beryl Institute, and hope that you'll also find the resources and information that we provide helpful in this ongoing dialogue as well. And in fact, just to share a little bit of information about the Institute, if you have not heard about us before, we're the global community of practice and premier thought leader on improving the patient experience. We currently have approximately 15,000 members and guests now in 30 countries around the world, having conversations like this on how we improve the experience for patients and families in healthcare, how we provide the right resources for caregivers and our healthcare workers to ensure that we have the best in-service quality and safety, as I mentioned, through bringing together resources by creating conversation, and ultimately by hopefully creating new thought and ideas that can lead us forward as we continue to design the best healthcare systems possible for ourselves and our families. So when we start with this conversation around patient experience, I always believe it's important to start with the idea of definition. And without definition, I say you have no basis for action. And I think that if right now we were shooting arrows, or if I was sitting in front of you in the room and we went the room dark and I was holding up a bow and arrow, you wouldn't want me just shooting it anywhere. So we want to ensure that we have targets, that we know where we're going. And so it's important that we have definition as a means and basis for action. And so I always ask people the question, how many people in the room, how many people online know that exercising or eating the right foods are good for you? And I can see you, so you can raise your hand. How many people know that those things are good for you? Now see, you've passed the first test today. We know those things are good for us, but sometimes we don't always do them. So how many people actually got out and did some exercise this morning, or didn't eat that chocolate bar or something like that? See, now look around you, the hands sort of change, right? So we understand that the things that we know are right and good aren't necessarily always the things that we do. And I call this the performance paradox. There's 6 words that I say are synonymous: simple, clear, understandable, easy, trouble-free, and painless. When you look them up in a thesaurus, when you look at them side by side, they all equate to the same idea, that they are sort of easy, simple, understandable. But what we find is that simple, clear, and understandable is not always easy, trouble-free, and painless. We know that when we think about eating right, we know that when we think about working out, and I think importantly, when we know what we need to do in healthcare to provide the best in service for the patients and families that we serve, while we know it's simple, clear, and understandable, it's not always the easiest, the most trouble-free, or the painless processes that we have to put in place. I think it's interesting because, as you heard in the introduction from the report that's pending, it's going to be critical that we involve the citizen more, the voice of individuals in this process. And so this is a challenge and a struggle that I think we will continually work on in organizations, not only in healthcare, but in organizations across sectors. So when we talk about definition, I want to bring you to some research that we did specifically in the United States, but what I found in translating it to my conversations with our global members and our global partners, that has a lot of truth to it overall, that when we look at how people are addressing the patient experience for patients and families in their organizations, many organizations actually have a formal mandate or mission. They believe this is something we must do. It's critical to how we deliver care. It's an important thing that we focus on. What I think is interesting is even more have a formal structure. They've actually, might not have a mandate or a mission, but they actually have put a structure in place to address some sense of experience, some sense of service, quality, safety for their patients and families. But yet, when you look to the far left on this picture in front of you, the formal definition, only 27% of those organizations we talked to actually had a formal definition, actually had a path, a target, a goal. And so I say, you know, and our challenge, I believe, still is that as we design the right kind of healthcare opportunities, the right kind of service quality and safety experiences, we have to be clear that we have that formal definition, that what is it that we're trying to achieve. And so as we look at that from the perspective of the Beryl Institute, we brought together a number of healthcare leaders around the world to talk through this. And we settled down on a very simple but concise term for patient experience as the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. This sort of shapes all the work that we do. It shapes what we believe is critical to improving and enacting efforts on the patient experience. We think it's critical as we think about the power of patient expectations, because it is every interaction, it is every touch point, not just simply what happens at the bedside of a healthcare organization, but what happens at the front door. It's what people believe and hear before they even walk in, when they're talking to a friend or a neighbor, when they're at the store down by their home, when they're shopping and they hear about a healthcare organization and what it's like. It's clearly shaped by an organization's culture, the fabric of what it's built on, the people, the behaviors, the actions, the commitment, the vision, the values of what that organization is about permeates through every choice and every action that healthcare providers and healthcare workers enact. And so to see that is critical, and that culture truly influences that. But at the end of the day, I think we have to be realistic, and this comes to the power of patient expectation. It is around patient perceptions. As much as we can put in every place and every proper design and every structure, it is what our patients and what their family members perceive that's going to influence ultimately the experience. And if we can begin to design and focus our efforts on how we help influence positive patient perceptions, I think we have a huge opportunity to make some improvement in this area. And lastly, it is across the continuum of care. The experience for patients is not delineated among segments or certain parts of their care experience. It starts well before they ever enter a clinical encounter and continues well after, when they share the stories that they've had, the experiences that they've had, the great moments and even the scary ones. And so understanding that patient experience travels that entire journey is important. So for me, when I talk about this issue, and I hope as we look at this as the opportunity, that it is about choice. We've probably heard the game rock, paper, scissors. That's about choice. Patients in systems all around the world, whether they are run by the governments, whether they are privately owned, whether they are nonprofit, still have some sense of choice in terms of where they're going to go, who they're going to choose to get their care from, how they're going to interact with the system. And so we have to consider choice as a critical piece, not only for what we do when we come back to that aspect of the performance paradox, but for what our patients and families have as they look overall at the healthcare experience. And so that leads me to have a discussion with you around actually what I believe is a market shift to experience, and what I see as a framework for understanding patient expectation. I'm going to offer three levers, three, I think, critical pieces to think about as this unfolds. And the first one really is this idea of choice, that we are moving beyond patient to consumer. I would say, and when we think about the idea of consumer, I get a lot of pushback. No, I don't suggest that patients are simply customers walking into a store, looking for the best service, pulling things off a shelf. Patients are partners, patients are co-creators in their experience, but they are consumers of healthcare. They do have choice in today's world, and they do begin to understand things. And I don't know if all of you, if you've been in healthcare experiences or if your loved ones have been, realize the power of the choices that are out there now, our ability to investigate, our knowledge based on the access to the internet to make real choices in healthcare. And this power of moving beyond simply a patient, recipient of care, to a consumer, someone that engages actively in their care, is significant. So just one example that came out of a study that was done by J.D. Power and Associates, and this was interesting. They found that the patient choice was truly a primary driver of patient volume. Again, based in the U.S. hospital system, but what's fascinating is if you look at that middle piece of data. More than 80% of patients and families surveyed said that reputation for skill and quality of care is the most important criteria they'll use in selecting a hospital, a doctor, a healthcare experience. So people think about what that experience is going to be like, how they hear about it, what they believe it's going to be, and that they in fact will then use ratings, and they will actually understand, they will use ideas of patient satisfaction to make choices around where they go in their healthcare experience. So I think it's important to realize that from the very beginning, that these individuals are coming into our healthcare systems today with more choice than ever, regardless of how restricted or unrestricted their options might be. The next one that I think is critical to think about for us is this idea of outcomes moving to the bottom line. Healthcare for the longest time has been around the opportunity to just make sure that you're better, that we've healed you, or at least done our best to ensure that you're feeling better than you did when you came into our care. Now that hasn't gone away. We're moving beyond that, though, to recognize that there is a bottom line issue in healthcare, that in fact when we focus on experience, when we focus on the expectations of patients, it truly impacts the business side of healthcare. And when we begin to investigate that further, I think we find some very interesting data. If you look at a study that was recently conducted by Duke University and the University of North Carolina, they used what we have here in the United States called the HCAP survey, which is a government-sponsored consumer assessment of healthcare providers and systems. It's a way to get a sense of how hospitals are providing the right in terms of quality, service, and care. And what they found was, in fact, when you compared clinical quality measures to experience measures, the experience measures actually trumped quality measures in how many people were readmitted to the hospital themselves. So when people responded stronger along the experience measures on how they would rate their hospital experience overall, or would they recommend that hospital to family and friends, they had a less chance of being readmitted to the hospital than people that scored higher on quality numbers, quality responses, but not so much in experience responses. So what we found was very interesting, that when you provide the right experience, that creates the right way to engage patients. That is the way to enact them. That is the way to ensure their expectations are met. They understand what's critical to them in their care. They understand how to take care of themselves after they leave, and they ultimately end with a better quality experience overall. So the design of experience and the insurance that there is good experience for our patients and families is a critical lever in ensuring the best in bottom line impact for organizations as well. And then lastly, of these three levers, I want to share one that I think is very critical. We've talked about patient-centeredness for a long time in healthcare. There was a study in the United States in particular done by the Institute of Medicine that I know has sort of permeated conversations globally around the fact that patient-centered care needs to be critical part of our experience in healthcare. That ensuring that we establish a partnership with practitioners, patients, and their families becomes an important linchpin, an important component of providing the best in care experience overall. And what's interesting about this is it's true. I mean, and I don't think any of us would say that being patient-centered as a process is incomplete. But I believe, and I like to suggest, that it's truly about focus. When we say patient-centered, it's how we get things done. And what we're finding out more and more, and I think as we look at the idea of patient expectations and designing the right healthcare experience, patients don't just want to be involved in the how or the what. They want to be involved in the why. So I come back to this concept of patient experience from the standpoint of what experience means. If we look at the definition, yes, there will be a quiz on this later, but if we look at the definition of patient experience, what's important is that we look at what it is from the standpoint of that customer, that consumer, that patient and family perspective, from that experience. And that is all that is perceived, all that is understood, and all that is remembered. So if we had a moment right now to stop and pause, and I was able to ask you all in the audience or online with us, if what you remember from your last healthcare experience personally, or for a family member, or for a friend, that's the experience. You might know that they were patient-centered. You might know that they were focused on you. But what you remember is that interaction and how you perceive that and how you understood that to be. And that influences everything that a patient and family member goes through. So I pose something to consider as we look at this aspect of patient experience overall. For as much as we can design, for as much as we can structure, for as much as we can create, for as much as we can work on improvement, what we find is that I see in hospitals and healthcare organizations all around the world is that we still segment our efforts. We might ensure that on the third floor of the hospital in our town, the east wing did some great things to become better. They redesigned their processes, they thought about their environment, they created the best behaviors in their people, but the folks on the West Wing on that same floor didn't have that same support or that same process. So what happens is, while we think we've provided the best in experience, the patient actually travels through our entire organization. For instance, here, that was something that they found at the University of Pittsburgh Medical Center. One patient that was coming in for a surgery on a single day was touched by 30 different departments. Now, as much as each one of those departments might design, create, and plan for the best in experiences, if they're not every single one in lockstep, the patient experience has a chance of being at risk. Because at the end of the day, that patient, that family member traveling with that patient only has one experience through all those departments. And I think we have to realize that that forces us to consider the implications of a systemic approach to what we need to do to drive the best in the patient experience overall. So as we think about that systemic approach, I'd like to talk a bit about the fundamental building blocks for designing patient experience success. As we've looked at hospitals, healthcare systems, healthcare organizations around the world, we found some fundamental pieces that we believe are important. And I'm going to share these blocks literally as blocks because I believe they're important to consider. And if you'll indulge me, I'm going to work my way from the bottom up. I'll talk a little bit more about those two foundational blocks, culture and engagement, in a moment. But as you know, at the center of the definition of patient experience that we discussed, culture is fundamental. Second is engagement of not only patients and families, but of staff members in the process, of the physicians in the process, of the community around us in what's happening. If we can get the culture right and engagement happening, then what we need is, you heard me say this before, a clear organizational definition of experience and how we ensure that we can have the right target, the right direction in terms of what we're trying to accomplish. A commitment at the highest levels of leadership, and we'll talk a little bit about the leadership implications in a second. I believe organizations need a focused role to support patient experience efforts. Someone that takes responsibility for ensuring that organization leads and focuses in a way that ultimately manages patient expectations, manages the needs of patients and families in a way that provides the best in quality, safety, and service. And ultimately, the recognition that patient experience is more than just a survey. So many people say, well, we have a satisfaction survey, or we ask them how they enjoyed their stay. Patient experience, as you've heard us say so far, is not just smiley faces on a sheet of paper. It's all that is perceived, understood, and remembered. And if we can put all these building blocks in place, we have a huge opportunity, I believe, to improve the patient experience across healthcare settings. So when we look at this foundation of culture, I'd just like to stress that a great example here from Sharp Healthcare in San Diego, what this chief experience officer here said is it's truly the culture. It's not any one thing they do, it's everything we do. It's what we do, how we do it, it's why we do it. And what you find is that building the right culture is a fundamental design component, I believe, of improving and impacting the patient experience. It's the foundation on which we build all of our efforts in healthcare today. And secondly, I come to engagement. And engagement is another critical component because it is the people in our organizations that deliver on those interactions that we talk about in the very definition of patient experience itself. Fascinating enough, at Grady Health System in Atlanta, Chief Financial Officer, the CFO that I spoke to, was the one that raised the issue of employee engagement. He said, in essence, if you don't have great employee engagement, if our employees aren't locked into why this is important, we're going to struggle the whole time to improve the patient experience overall. So this gets into the power of co-creation and engaging our members of our healthcare organizations, our staff, our doctors, our communities, as I mentioned, to ensure the best in experience overall. So what we heard from leaders in this was critical. How can we then, from leadership perspective, work on driving patient experience improvement? I come back to some of the research that I shared with you before, and I ask you, in essence, if you find this to be consistent with your own experience as well. As you look at designing, as you look at ensuring the best in experience opportunities in healthcare today, what we found the roadblocks to be, and I'll start there first, was truly just a general cultural resistance to doing things differently. What was amazing to me, and then I've had the opportunity to travel around the world and talk to people, is that any hospital that I tend to walk in, any physician practice, surgery center, or other location, I so often hear people saying, well, we tried to change that, but that's just not the way we do things around here. Or they've struggled with making change because people are so committed to their work that we struggle with how we improve or make changes overall in the healthcare system. So that cultural resistance to doing things differently does permeate healthcare, and it's a challenge that we need to overcome. Also, we have leaders that are really diffused in their efforts. As I said, it's important to have a focused leader to drive patient experience efforts. What we find is that we don't often allow that to happen because we have so many accountabilities, so many responsibilities that we ultimately diffuse what patients, workers in healthcare can accomplish by that very effort of applying too many responsibilities and not enough focus on what's critical. Now, on the reverse side, if you look at what leaders said, number one, by far, strong visible support from the top. Those organizations that we find that have been effective and successful in healthcare delivery, in effective and positive patient experience, have had clear and unwavering support from their senior leadership. But then that leadership permeates throughout the organization, that people understand their responsibilities in terms of delivering on that experience. Because as much as we talk about creating the right framework, those building blocks, designing the right systems and processes, environments for healthcare, if we don't have the people to deliver on that and we don't have the support from the leadership structure to ensure that it happens, all of that is for naught. And so the opportunity to create the right structure of support, I think, becomes important. So as we talk to these leaders about the supporting factors of patient experience, which I believe leads us back to the power of patient expectations, is this, that we do need to create cultures of trust, that people in those cultures understand why it's important and they trust in us as patients and family members, as community members in terms of what we can deliver, that we have that level of unwavering leadership support, that we have clearly defined and efficient processes, that we align our resources, but what I think is even more important is align our people. All the organizations that I talk to and those that are most successful work on having what I call the right people, quote unquote, the right people on board. Those folks that you know are going to actively engage in ensuring the best and quality service and safety in your organization. Not those that are the naysayers, or we've all had that nurse sometime that we wonder how she got into nursing in the first place, I know. And yes, she's probably a great clinician, but she might scare us out of the room on occasion. But then it's helping staff understand why what they do is important and why the overall structure of this is important. And lastly, and not because it's least important, but because it's most important, is we have to engage the voices of patients and families. And I come back to what you heard earlier about the great research that's being conducted right now and the report that's pending about the power of engaging the voices of the community, engaging the voices of the citizen. In healthcare, we can be no different, that we have to engage the voices of patients and families to ensure that we manage expectations, to ensure that we drive the best in experience. So from the patient's perspective and looking at expectations, or what I like to say, what is really important, how does this all come together? And I see very often in healthcare that we like to divide these segments: quality, safety, service. We sort of separate them as different buckets that we need to work on. And I have had wonderful and very positive debates with many folks in these different areas that they say, well, we need to focus on our quality efforts, or we need to focus on our safety efforts, or we need to focus on our service efforts. And I say, in fact, back to what we said, patients and family members don't delineate between these. If we design structures to manage things in separation, we've missed the opportunity from the eyes of the consumer. Because when the consumer looks at these three pieces together, they see the experience in total. Quality, safety, and service to them is the patient experience. It is every interaction that they have, as we said, across the continuum of care. And it was no better exemplified than in some interviews I'm doing for a paper that we're about to put out on voices of patients and families, which will be coming out this spring. And I'll read this to you just because I think it's so poignant and so powerful. It's time for us as patients to no longer be subjects in the care experience, just diagnoses to be treated, diseases or illnesses to be cured. We must be partners in the process, engaged for our voices, understood for our personal needs, included in the decisions to be made. This is the opportunity I believe we have in improving the patient and family experience, and this is what I believe really matters. So as we look at what matters, I share with you a story, and if we had more time, I have a number of stories I'd love to share with you, but this one in particular. If you can imagine now a hospital room in the hospital in the community near you, and in the bed there's an older woman who's sitting there, and she goes to her bedside table to get a drink of water. As she reaches over to the table, she knocks the small cup over and it spills on the floor. So she calls on her call light for the nurse, and she presses the call light, and no response. She presses the call light again. Of course, the nurse is probably busy. She presses it one more time. The nurse finally comes into the room, and the patient, I think very positively, says, I just want to let you know there's a spill on the floor. I don't want anyone to get hurt. So the nurse says, hold on a minute, walks over to the phone on the wall and calls the housekeeper. So now there's a spill on the floor. The nurse is on the phone, the patient in the bed. A few moments later, you hear the squeaky tires of the mop and broom coming down the hall. Eater, 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 right? And in the room comes the housekeeper, there's the nurse, and the patient in the bed. The housekeeper looks at the spill, looks at the nurse, looks at the spill, looks at the nurse, and just does one of these, waves the nurse over. And if you've ever heard this, I'm sure we've all seen it, probably if nothing else with our parents, at some point when we were kids, a whisper fight ensues. That the nurse and the housekeeper are back and forth like this. And their whole fight is over, this spill isn't big enough for me to clean up, you should clean it up. This spill isn't big enough for you to clean up, you should pick it up. And literally, here's a nurse and a housekeeper arguing over the size of a spill in terms of what needs to happen. Well, in the midst of this whisper fight back and forth, they hear this splash of water. They both pause, they turn around, they look at the patient in the bed, and she's sitting there with the pitcher of water upside down on the floor, water everywhere, looks at them both and says, is it big enough for you now? And the reality of this is we have to make it big enough for us now. The patient expectation is that every opportunity is big enough for them now, that we need to include their voices, that we need to ensure that as we design and consider patient experience in healthcare, that these are critical considerations at every point along the way. So it is about overcoming the performance paradox. If we can recognize that simple, clear, and understandable is not always easy, trouble-free, and painless, we still have the opportunity to make the right choices. It is around having the right definition for ourselves. So I encourage organizations in healthcare to either adapt or adopt a definition. We offer ours as a template and a starting point, as long as we remember that it's about interactions, it's based on culture, it's across the continuum of care, and at the very essence and its core, it is about the perceptions of patients and their families. And lastly, we have to remember it's about choice. The same way you all got up and chose to come here today, you chose to, I saw someone eating an apple earlier to be healthy, or do that workout in the morning. We have choices every moment to ensure the best in experiences for our patients and families in terms of how we provide, design, and ensure that those things happen. So I encourage you to go out and make the right choices, support your caregivers and your family members in doing that as well. And I thank you for the opportunity to spend some time with you talking about this critical issue today. And I look forward to some questions and conversation.
Thank you so much, Jason. This is really too much. Who will pick this up? Who will? Where does it start?
Where does it start? I think it's interesting because I think it has to start with those folks that have the passion to engage. You know, as much as I can say that leaders and organizations are those responsible parties in holding the container for it to get done, I've seen patient experience efforts be spurred by the smallest corners of an organization that believe it's important. So it has to happen, I think, one, from inspiration, but it has to also happen, two, from a level of commitment and a recognition that it's a strategic need. So I think you see more often now that governments, in particular, if we look across a number of countries now, are putting in processes, requirements, surveys to ensure that this is part of the conversation. I would hope that would not be the motivating factor, but more of a means to measure performance. For me, it's about making those choices in healthcare to realize that if the ultimate in experience is quality, safety, and service, clearly we know outcomes are important, but we remember that as human beings, all we are in healthcare is human beings caring for human beings. So it is about creating that environment of respect, that environment in terms of honoring people as those human beings, and then making those choices every day. So back to the point of your question, I think it's about who's going to make that choice. Leaders, the systems that support them, and even people on the front line that know that they can make the choice every day to do the right thing.
Thank you. We have a microphone in the room, so if there are questions, and we have a Twitter flow. We had connected to that, we had a question: how does the trip from bad results to good results look like? How long does it take?
You know, it's a great question. I mean, that's an organization change question, which is my background. And I know that if you look at people, the general conversation on culture change and organization change, they say it can take, you know, anywhere from 2 to 3 years for that to happen. Now, I'm going to challenge that conventional wisdom. I'm going to say that it's about choice and the fact that change happens at a moment of choice. If we can begin to create the choice of people to behave in different ways, to understand what's important, you can make that happen very quickly. It is ensuring you have the right people on board. It is ensuring that you have the right processes in place, which do take time. But the choice to treat people with dignity and respect, the choice to provide the best in experience, isn't something that takes a great deal of time. It's the choice between saying, well, today I ate a vanilla ice cream cone, and tomorrow I'm going to eat a chocolate one. And if we can begin to think about that, I think we can actually make rapid change and create agility in the organizations today to be able to take that journey in a very rapid way as well. So I don't think it takes a long time if we're willing to make that commitment and make that choice.
We have a question here from Anna on Twitter. I agree to the importance of patient experience, but how do you get money allocated to start it? Where does the budget come from?
Well, that's a great question. I think I have a lot of folks that play the role of patient experience leader right now asking me that same question. And I think it comes back to the arguments that we shared today. I mean, the reality is that if we recognize that patients today, as much as they are patients and they have very unique circumstances and very trying situations that they're faced with, are consumers in what we're trying to accomplish, that we have the opportunity to ensure and reinforce that with that choice and the opportunity, even in systems where people are supported, that the service experience for people is a critical means by which we create the right reputations and in fact better outcomes, that's the key. So to be able to make the case, back to the study that I shared, that whether you know that people have to come or whether they have their healthcare paid for or whatever those choices might be, that still fundamentally providing experience leads to better outcomes for people, which is going to ultimately reduce healthcare costs, which is ultimately going to ensure healthier people, which has larger societal impacts as well. There's some significant cases to be made to say it's worth that investment. And so I think each organization has defined the right pieces and parts of where it's willing to make that investment. But I think making that argument for this being a critical component of driving the best outcomes for patients and families, for driving the best positioning of our organization, healthcare organization, the communities that we serve, it does become both a business and, I think, a conversation about the right thing to do.
So much to think about. If you have questions in Swedish, you can ask questions in Swedish. We could translate them. I was thinking, sorry, it's just that it makes me think a lot about the different things. So let's get back to focus. You were saying before that there are a lot of organizations that have a mandate or a structure for these things. But is it a good thing or a bad thing that they have it? When is that a good place to start, to find organizations that actually have a structure and mandate?
Well, it's interesting because I think a lot of, I mean, I would, if I asked everyone in the room if they thought it was important that that every organization focus on patient experience. How many people think it's important that you focus on patient experience? Raise your hands. It's an interactive exercise. Is important that organizations focus on this? Yeah. So I mean, most people, everybody will say yes. So the fact that organizations have mandates, to me, sometimes becomes a bit of an empty promise, because we know it's important, and there's a lot of promises, I'm sure, even outside of healthcare, just consumer promises in general. We're going to provide you the best in service, but when you go to that store that it's not. So saying something, knowing it's important, having a mandate isn't, to me, as important as then moving to, we talked about structure, but then really moving into process. The telling component for me is that number, as we talked about in that discussion, was definition. That when only a quarter to a third of organizations can truly define what it is they're trying to accomplish in that, it's really hard to enact anything effectively. So as we think about designing the best in experience and kind of structuring the way that we look at healthcare, if we don't have that framework or that definition, then we're at a loss. So I don't think we could walk in any hospital. We could go down the street from where the offices are right now, where you are, and ask them if they believe it's important. And I would think that most people would say yes. Does that mean they've actually enacted something, put a definition in place, and have a strategy to address it? Is a very different thing. And so I think it starts with that choice, moving away from just the acknowledgement of mandate to clearly putting a stake in the ground around what it is we're ultimately trying to accomplish.
You were saying that, I mean, good results in the patient experience is a predictor of that quality is good. Mm-hmm. But then when we come with this and when we say this, perhaps they will answer, well, okay, it's a predictor of whether quality is good, but it's not a tool to work with quality. I mean, quality is something that, and safety is something that we work with internally, and that's not for patient or connected to patient experience. How would you respond?
Yeah, I think that's interesting. What I would say is that if you think about quality from the standpoint that I look at it, or safety, I mean, we can look at the issue of safety, which is reducing falls. We're ensuring that we move patients enough so that they don't get bed ulcers or those sorts of things. If we look at quality to ensure that we're issuing medicines at the right time, that we've managed our medications, most of those things become checklist opportunities. That quality and safety, from my standpoint, is around the tactics and delivery of care. That there's that book, The Checklist Manifesto from Atul Gawande, that you can see that when we build the right checklists, we can ensure the best in quality and safety. So you can structure those a lot easier, but those still fit within, I think, an experienced environment. So while we can do checklists in quality and ensure the greatest in quality in people, if I'm laying in bed and I know that you went through your quality checkdowns and I've had everything was taken care of and that you gave me my meds, but at the same time you treated me like a piece of garbage, literally, or you didn't recognize me really as a human being, but just something to be checklisted off or something, that's going to influence my overall experience. It does actually impact my care. It was interesting because we just had a webinar yesterday that we shared where a nurse clinician, 30 years experience, said that in fact patient experience needs to be framed as a clinical imperative, a clinical initiative, from the standpoint that when you provide the right experience environment, you create a healing environment. And in creating a healing environment, you in essence enact, if you've heard, the placebo effect, the fact that people feel as if they are better, as if they're being respected. And when you actually create that environment, what you find is immune systems, in science, immune systems respond with greater strength, that healing times are reduced, that all of these things occur. So there's actually science behind the fact that I believe experience in creating the right kind of environment for people for healing makes a significant difference that has as significant of impact, if not greater, on some of those quality checklists that you talk about. So I think if we just focus on quality and safety because we know it's important, we take the humanity out somewhat of healthcare, because we are, as I said at the beginning, human beings taking care of human beings in this process.
We have a question here. Who has the responsibility to define what experience a patient should have? How decides what should be created?
I have seen this done a number of ways, and I believe personally from my experience that this is a co-created opportunity. That in particular where healthcare organizations provide care in their communities, they're part of that community. So I would envision that it's not just the leaders of an organization, but it's the frontline staff, the caregivers in that organization, but it's the community members, it's patients and families that have been part of that. I think the organizations that have been most effective, and I've seen it done to some extent, and I would encourage that it be done more, had even summits where they brought together the voices of all those people in a room and said, what do we want the patient experience to be like in our hospital, in our medical center, in our physician practice? And when you bring those voices together, you get the most comprehensive perspectives. I think you get the most inclusive definition, and you also create buy-in immediately. Now, that takes a lot of time, a lot of effort, so I know organizations that have also done that at a much smaller scale. But I think what's important is that you validate it with your community, that you ensure that it makes sense with your patients. And it comes back to that quote that I shared. If we continue to make patients subjects of care versus partners in it, I think we're missing a huge opportunity. And so the definition process needs to include all those voices, and I think that's the most effective way to enact and create the right definition for patient experience overall for any organization.
Another question here is, what do we already know of health science, education and training, like medicine, psychology, that teaches these concepts?
Well, I mean, I think it's embedded in a lot that we know. I mean, I think that as we look at general science around healthcare today, and it comes back to what I was sharing before, even about this webinar that we had yesterday around creating healing environments, that when we look at the science and the focus on healthcare, we know that it takes the right environment, the right kind of attention, the right focus to ensure that people get better. It's not just the medicines, it's not just the prescriptions that are what happens. It's the behaviors of patients, it's their engagement in the process, it's the environments that we create. And by framing a better experience, you've created that level of engagement from patients as well. They're doing some research now, and I haven't had a chance to read it completely, but on how when you engage patients in their care and ultimately involve them in their diagnosis and then ultimately their plan of care, they leave a hospital or a healthcare setting knowing what's expected of them. They actually know more effectively how to take care of themselves, what medicines, what timing, what it means. And when you create that level of engagement, I think you shift the potential outcomes. So I believe, science is showing that creating the environment of healing, creating the engagement of patients and understanding the value of those meds, understanding the value of care plans, understanding what happened to them in a way that they're not just subjects to care but partners in care is critical and probably going to be the next place that we truly need to invest time and effort to ensure that not only do we provide the best in quality of care, but we manage in a society globally that the cost of care continues to increase and increase and increase because not only the volume of people that need care, but because of the situations around us. So the more we create co-ownership and co-creation in this process, I think the better chance we have of managing cost, managing outcomes, and providing the best experience overall.
What would you say is negative with focusing on patient's experience?
What would I say would be negative about focusing on it? Is that a trick question?
No, it's an actual question.
I think
it's a real question.
No, I agree. No, I agree. I can't, it's a great question. I've been asked this before. And, if we believe that experience, as I frame it, is all about quality, safety, and service, I can't see a negative in focusing on it, as long as it doesn't become an initiative. And so this would be the one time where I have seen it turn into what could be perceived as a negative, when staff feel like they're being told to do something. And in fact, again, I'll reference the webinar yesterday. It was fascinating that they said that on occasion, nurses who are trained clinically to care for patients and their well-being see patient experience simply as a service initiative or a smiley face effort that gets in the way of providing care. I have seen nurses resist, and I have seen them say it's done in the care in their belief that they're advocating for the patient, that the service efforts or these smiley face initiatives or these plans are in the way of providing the best in care. That's when I've seen patient experience potentially be a negative, and that's when I would say it's been done in a way that hasn't been beneficial to the organization. Patient experience is an initiative. It's not just something that we say, this year our focus is. It is, in essence, patient experience is all that we do in organizations. When you think about it from the standpoint of how a patient engages with us, how they understand what we do, how they actually come through our system, and then what they share when they leave is all part of their experience. And we have to frame that. We have a huge opportunity, and we must, I believe, frame that in a way that provides them with the most positive experience as possible. So the negative side, to your point, is challenging. And I think it's when you turn this into initiative, a checklist item, or just some other component of strategy that's not part of the comprehensive nature of what you're trying to accomplish overall as a healthcare organization.
If I was CEO of a hospital and I decided I want this to be the best workplace in the world, I want this to be the best workplace with the most engaged employees, how would I use this? That's not my focus.
How would you use this, meaning?
Patient experience.
Oh, well, if you look at the foundation of patient experience as engagement, then I think the first thing you have to do is actually build the right workforce. You can't create an environment of patient experience without it. In fact, just visited a hospital recently that when you asked them what their strategy was this, that the first thing they dealt with in building a patient experience strategy was their high, medium, and low performers. They said, okay, we have people that can definitely help move us forward. There's people that are struggling but can contribute. And there's people that are actually detracting from what we're trying to accomplish. And so the first thing that they did was manage the people. They worked on what it was to have the right people on board. I think you saw that as well in the list that I shared about executives. And only when you build the right people and find ways to engage them and then ensure a culture that reinforces and expects the kind of behaviors necessary. So exactly to what you're saying, Andreas, the right kind of workforce, the best place to work, that's the foundation on which you create a strong patient experience. It's not distinct from. So if you're not willing to do that work first, if you think you can just lay patient experience on a workforce that might be not committed to this work, it's like building a house on sand. It's going to shift, break, and potentially fall down. So you have to really, I think what you're saying, recognize that that is the foundation, or really the first step to what I believe enables truly the best in a patient experience overall.
We have a comment here. I'm worried about the connotations of consumerism. Why not instead expand the patient role or use a word citizen?
I like that. And I think that's probably a very good point. You know, I think the consumerism, I think, does have potentially negative connotations. And I think that there's probably a way to evolve that word. I think the important part in the important point in that comment that you share, and I agree with that individual wholeheartedly, is that we have to recognize that a patient isn't just a recipient of something anymore. They're a partner in the process. And they do consume services at the hospital or at the healthcare organization or at their physician practice. They do engage in that process. And I think now, as we look at how people make choices in healthcare, they do play the role of consumer a lot. So I don't want to diminish the fact that they are. I don't want that also to be perceived as limiting in terms of the critical nature. And I think, as you said, that patients are citizens in the process, that healthcare, I think, as much as it has been hierarchical historically, and I come from a family where my grandfather was a pediatrician, a head of pediatrics at a hospital, and he was lockstep. And when he said what happened, all the nurses followed and the patients did what they said. I think we find that's very different now. The perfect story to this comment is that I was on a plane flying not too long ago, sitting next to a gentleman who found out what I did, and we started talking about patient experiences, a lot of folks do. And he said, well, my mom lived in New Jersey. She had a hospital down the street that she always went to. She needed hip replacement surgery. And so the expectation was, and her doctor had already assumed, that she'd just go down there and do that surgery. And the receptionist at the doctor's office really angered her because she treated her poorly one day. And she said, well, I'm going to do some investigation. And this 80-year-old woman got on the internet, researched hip replacement surgery, found a new procedure, realized that this was a less painful and a higher chance of recovery with a shorter recovery time, found, in fact, that there was a physician in Florida that had a specialized surgery center for this kind of hip surgery, and chose to buy a plane ticket, fly to Florida, and get her surgery there, rather than go to a hospital that she could drive a few moments away and get her surgery. So as much as we say, and I agree, consumerism is not necessarily the right word, people are making consumer-like choices in healthcare today. And I think we have to recognize that it's shifting the nature of healthcare overall.
And have you seen any examples of reimbursement systems connected to patient experience in any way?
Yeah, 100%. If you haven't heard about what they're doing here, actually in the United States right now, it's fascinating because I mentioned this HCAHPS survey. HCAHPS, as I said, stands for the Hospital Consumer Assessment of Healthcare Providers and Systems. And there's a set of questions that every patient is asked to complete. Actually, they have to do a sample size, but every hospital is required now to contribute to this. And based on scores of experience, that's part of an equation that influences how those hospitals are ultimately reimbursed. And in fact, that just started this year, and there are some hospitals that actually have lost reimbursement dollars as a result of poor quality and or experience scores. And there are some hospitals that actually made more money as a result of outperforming in those scores. So that is a process that they're trying right now here in the United States, and I think it's created a lot of controversy with some folks that think, well, this is objective, or this is not objective, this is just subjective responses of patients. And I think that's the magic in it. I mean, when we look at the definition of patient experience, at the core of it, as we shared, was this idea that it's about patient perception. And as much as we design, believe, structure, what our patients believe is true is true. And so that does influence reimbursement. It's doing it right now here in the States. I know, for instance, in Ontario, in the province of Ontario right now, actually executive performance, as all of those CEOs of hospitals in Ontario are employed by the government and the Canadian healthcare system, their performance bonuses are tied to experience scores. So there's lots of different ways that I think you're seeing financial levers being used in experience overall. And I think it's going to become more and more prevalent around the world as we see this evolve.
Talking about financial levers, have you seen also effects on the cost side?
Yeah, I think that people would say, well, focusing on experience costs more. I think that, because what they're accounting for is the initial investment sort of the upfront dollars that it might take to say, well, we've acquired a specific resource, or we've invested in these kind of programs, or we've made these physical improvements to our facility to ensure that there's a better experience. I think the cost benefit or the return on investment is much more significant. In fact, back to your financial lever question and the reimbursement piece, I've had a few hospital CEOs here in the United States say to me, Jason, I don't have enough dollars at risk with that survey to invest all my time and dollars in here. I'd rather go invest in a new service line, or say potentially a new gamma knife, where I can create many more surgeries in that experience and make much more revenue as a result of that ability to provide those surgeries. And to that point, I think it's narrow-minded, because you're looking at a pure dollars to dollars comparison. And as we talked about today, when you invest in experience, you create a broader window of opportunity. You create reputation, you create the willingness of patients to come, you create the potential for reimbursement, not simply dollars lost in a simple survey equation, but I think a much bigger potential in terms of revenue. So I think what organizations are finding is, while it might cost upfront, the return is much more significant, because it comes back down to that choice that we talked about before. I believe people have choices, they're going to make choices, and it's going to be influenced by the kind of experience they have in healthcare.
Have you seen any research on return on investment on patient experience?
I believe it's just starting to come out. The one that I cited today is one of the best ones I've seen. And it's not even a direct ROI study, but the one that I shared from North Carolina and Duke that showed that ensuring that people responded more positively on those questions around experience, even then performing on the quality questions, led to better reimbursement, led to lower readmissions. Lower readmissions leads to better cost management. It also, in the United States here, lower readmissions has an implication for other components of reimbursement as well. So there's indirect studies like that, but I think, Andreas, to your question, it's something that I'd like to see more organizations do. I'm encouraging them to do, and it's something I'd like to see us investigate further at the Institute as well.
And how do you think that product design can improve the patient side of healthcare practices by working on healthcare research labs?
I think 100% it can. It's fundamental to ensuring the best in outcomes. Because if we think of experience as all that's perceived, understood, and remembered, and if we think about it from the way I perceive design, engage in design, as all that's kind of seen, touched, felt, experienced, smelled, all of that, that ensuring the right kind of structures are in place, the right kind of design is in place to frame an experience for people is critical. I had a great opportunity to visit some labs where they were doing scenario testing to see how it influenced the way that patients engaged and patients experienced that. I believe also that, as you talked about earlier, the opportunity to co-create, to engage patient voices, family voices in those design processes is critical. It comes very back to what you heard in the introduction before I began speaking about even the work that's being done there, that it's important to include the voices of the citizens. So I think it's a critical component. I think more organizations need to think about it, and you'll see that if it's in the most simple of design processes or the most complex, those that are being successful today are finding ways to engage the voices of patients, families, and really the community in general that they're trying to serve.
Finally, we're ending up here. What would you say? What's the case you love the most? What have you seen that you really love and feel that they have done something really, really special in real life?
There's plenty of stories that I could tell about things that I've seen, and for me, the magic of experience is when you hear stories about that caregiver at the bedside, or even that building engineer or that receptionist going above and beyond to ensure that that person they're interacting with in the moment is having the experience they deserve, and one that they probably didn't expect. So there's millions of stories like that, but I'll give you just one simple example. And I think that I'd encourage you, if you want to read a broader one, I don't have time to tell you now, there's a great case on Florida Hospital, which is in Orlando. It's an on-the-road story, and it's available on our website at the Beryl Institute. But an example of a CEO that I've worked with closely is Dr. David Feinberg. He's the CEO of the UCLA Health System. And he says something simply: if you show me the patient that deserves any less than the patient that came before, that's when we can stop. And he goes out every day and rounds 2 hours. As a CEO, 2 hours walks the floors of his hospitals, not just to talk to patients and families, but to talk to his staff. He goes behind, backstage, in essence, as they call it, behind the scenes to housekeeping. He walks the halls, and he reminds people of that one thing, that if we recognize that when you can show me the patient that deserves any less than the patient that comes before, we can stop. That's the essence of this all. And I think it's the essence that drives, I think, the patient experience effort and should drive it for organizations really around the world.
Thank you very much for letting us be with you this early morning.
I appreciate it.
And we will continue discussions on Twitter. We have a LinkedIn group. It's called Design for Better Health or Design for Bättre Hälsa. I think if you search, you will find it. We will have the next webinar in 2 weeks, the 6th of March. It will be in Swedish about design in the healthcare area. En nulägesbild with Eva-Karin Anderman from the Stiftelsen Svensk Industridesign. So thank you very much for being here. Thank you, Jason, and bye-bye.
Thank you all. Have a great afternoon.